Hello and welcome to this seminar of today that's called SGLT2 inhibitors and hemoglobin increase, a possible explanation of the cardiovascular benefit. Today it's my pleasure to introduce our speaker, Professor Lucia del Vecchio from Lariano Como in Italy, and our panelist, Dr. Olga Balafa from Ioannina, a nephrologist, well-known nephrologist from Ioannina in Greece, and Professor José Manuel Valdivielso from Lleida University in Lleida, Spain. This is an seminar promoted by European Renal and Cardiovascular Medicine Working Group, EuReCa-M, and this is a very nice topic because we already know about the cardiovascular impressive mechanisms of SGLT2 inhibitors and renal mechanisms of SGLT2 inhibitors. But today we're going to talk about a very nice pleiotropic effects that we have found with these drugs. So Professor Lucia del Vecchio, the floor is yours, and we are ready to hear you. Thank you.
Hello, everybody, and welcome to this symposium. It's my pleasure to be invited also as a former member of the EuReCa-M working group. And also, I'm very happy about it because this is a fascinating topic that probably we will give in the future very, very exciting experiences. These are my disclosures. Well, the first answer is, do SGLT2 inhibitors increase hemoglobin levels? Well, the answer is obvious, yes. If not, we wouldn't be here. And then, is this something new? Well, as a matter of fact, not really. I went back at this publication in 2010 from data from a phase 3 multicenter double-blind study that was designed for registration purpose in patients who had inadequate glycemic control with metformin, and more than 500 patients received dapagliflozin at increasing doses for 6 months. Well, if you go at the change in hematocrit during follow-up, we can see that patients receiving placebo are no changes or a trend toward decrease. And then we can see an increase in hematocrit level that was dose-dependent, with patients receiving the highest dose of 10 milligram having the highest changes. But then more data has arrived, and of course, I wouldn't show all them. This is a good paper back in 2020, collecting data from 14 trials with dapagliflozin of more than 5,000 patients and at least 6 months of duration. And you can see from this slide that since for the very beginning, already after the 4th month, patient overall can increase a significant increase in hemoglobin level, and the increase then continue and persist over follow-up. The slides show you the trend in non-anemic in blue and anemic patient, and you can see the effect is observed in both categories. And what else? Well, patients who had anemia at baseline over follow-up, if they were treated with dapagliflozin, were more likely to become non-anemic compared to patients who received placebo. On the other side, patients who were not anemic at baseline had less likelihood to becoming anemic if receiving dapagliflozin compared to patients treated with placebo. But which kind of patients were included in these studies? Well, we can see that a minority of these patients had severe or advanced chronic kidney disease. These are the type of patient in our experience that develop anemia and need anemia treatment. And well, let's have a look to, let's say, studies including more advanced kidney disease. The first one is a Credence trial. It enrolled more than 4,000 patients with type 2 diabetes with a GFR between 30 and below 90. The authors published a dedicated secondary analysis on anemia. We can see that in this population, the presence with anemia was evident, with 1/3 of the patient having anemia. And However, you can see that just a minority of them were receiving a treatment for anemia that was either iron preparation or erythropoiesis stimulating agents. And these are the effect of canagliflozin on hemoglobin according to patient subgroups. Overall, we can see that patients treated with canagliflozin had similar hemoglobin levels as those receiving placebo, and the mean difference in hematocrit during follow-up was 7.1 hemoglobin, sorry. If we look for patients who were anemic or not anemic at baseline, we can see again that all the patients had an increase in hemoglobin regardless their anemic status. The same if we look at the degree of kidney function. You can see that the increase in hemoglobin level was similar across all the degree of kidney function. And finally, let's have a look to patient receiving treatment. And we can see that patients had hemoglobin increase whether or not they were receiving iron preparation or stimulating erythropoiesis agents. And another trial that involved a patient with even more advanced kidney disease is the DAPA-CKD. In this study, more than 4,000 patients had eGFR between 25 up to 75. Nearly 2/3 of the patients were diabetics, whereas 1/3 had not diabetes. And these are the baseline characteristics according to the presence or absence of anemia in the treatment group. As expected, patients with had no anemia at baseline had higher hemoglobin level compared to those being anemic and higher GFR levels. Again, only a minority of patients were treated for anemia that was either or iron supplements. And these are the trend of hemoglobin level during follow-up, depending on treatment group. Again, you can see that there is a significant increase in hematocrit levels in patients receiving dapagliflozin, whether they were anemic or without anemia. And what is the effect of dapagliflozin again on hematocrit according to baseline's group? We can see the effect is present in the presence of diabetes or its absence, possibly with more efficacy in patients who are not diabetic, effective for all the different cutoff of eGFR and for the different cutoff of proteinuria. And well, the first question that we can ask is it hemoconcentration or a true effect? Well, it is now established as a certain that this is a true effect. Indeed, patients treated with SGLT2 inhibitors experience a drop in body weight around 2-3 kilos, especially at the very beginning of treatment, partially due to initial hemoconcentration, partly due to a true weight loss. However, the diuretic effect of SGLT2 inhibitors is very, very mild, and more importantly, does not last over time. Conversely, several data clearly shown that this increase in hematocrit is due exactly to a stimulus of erythropoiesis. These are findings from EMPA-HEART CardioLink 6, a study on treating patients with empagliflozin to observe changes in left ventricular volume and spessor. And according to this secondary analysis, you can see that patients treated with empagliflozin had a sharp marked initial increase on erythropoietin level that was not observed in patients treated with placebo. However, during follow-up, this increase in erythropoietin level was not any more significant compared to placebo. And also, patients treated with SGLT2 inhibitors experience an increased availability of iron that is expressed but a decrease in serum ferritin, as you can see here, and a tendency to a decrease in transfer saturation, as it is observed with treatment with HIF-PHI inhibitors. And the second question is, do the anemic status and the anti-anemic effect of SGLT2 inhibitors can influence patient outcomes? Well, the answer is yes, we are on the green side of the bar. And let's have a look at what kind of data support this. This is a secondary analysis of DAPA-CKD published on New England Journal of Medicine Evidence in 2023. And the authors express the absolute risk of reaching an outcome or the hazard ratio, depending on the absence or presence of anemia. And quite interesting, you can observe that patients who were anemic, as a matter of fact, seems to have more benefit from treatment with dapagliflozin compared to patients who are not anemic. And this seems constantly true for all the endpoints, that is the primary composite outcome, including eGFR decline, end-stage kidney disease or kidney cardiovascular death, secondary outcome, kidney secondary outcome, cardiovascular death or hospitalization for heart failure, and all cause of death. And other interesting studies are entered more in depth whether the change in hemoglobin level can explain the positive effect of SGLT2 inhibitor. This is a secondary analysis of the CAMBRAS program. In this study, the authors collected 19 different biomarkers and compared them, their linked hazard ratio for their fat and randomized treatment in an adjusted and adjusted model. And very, very interesting, hemoglobin, the change in hemoglobin had the highest effect, higher than the change in uric acid or hemoglobin, glycated hemoglobin levels. Another interesting analysis comes from the EMPA-REG outcome trial. The study included more than 7,000 patients with type 2 diabetes and established cardiovascular disease. Overall, empagliflozin, given in addition to standard of care, reduced the risk of cardiovascular death by 38 versus placebo. Exploratory mediation analysis is a kind of analysis that establishes the extent to which treatment-induced changes in specific variables, either alone or in combination, contributed to the reduction of a given risk, in this particular case, in the risk of cardiovascular death. Again, very, very interesting, and you can see from this slide, univariate mediation analysis show that hematocrit and hemoglobin were the most important contributor to the positive effect of empagliflozin, contributing to half of the effect. Very recently, the same analysis was performed on the same trial, but taking into account kidney outcome. Again, you can see that hematocrit or hemoglobin were the most important contributor to the positive effect of empagliflozin on kidney outcome in this patient. And what can explain this positive effect? Which could be the connecting link? Well, we all know that erythropoiesis is a response of the body to hypoxia and is mediated by action and changes of hypoxia-inducible factors. And we also know that hypoxia is an important factor physiological present in the kidney. Why? For several reasons. The first reason is we know that the kidney is a organ with a very, very high metabolic activity, and this implies high oxygen consumption. Moreover, according to its structure, and especially the medullary outer region has a very, very low oxygen content. For this reason, when during pathological states, there could be acute kidney disease or chronic kidney disease due to fibrotic changes and damage, the trend of hypoxia in the kidney could worsen and increase several mechanisms contributing to kidney damage. In particular, fibrosis can reduce capillary density, increase interstitial extracellular matrix, and increase the distance between capillary, and for this reason, reduce the quantity of oxygen that can reach cells. And well, several interesting experimental studies are becoming available, try to put in connection hypoxia, which is, as we said, an important mediator of acute kidney injury and tubular damage or chronic kidney disease, and the effect of dapagliflozin in being nephroprotective in several occasions. In these particular experimental studies, rats were divided into 4 groups of treatment: control group, diabetic group, diabetes plus contrast media, and diabetes plus contrast media developing acute kidney injury and receiving dapagliflozin. And interesting, we can see that in control group, the oxygen flux was normal. You can see that following hypoxia, the oxygen flux is reduced in control group, but we can see that dapagliflozin can markedly reduce oxygen flux, and this effect is also maintained during hypoxia or when giving a silencer HIF-1 activity. Interesting, the same effect of exposing cells to hypoxia, we can see that hypoxia increases the percentage of apoptotic cells. The exposure to hypoxia plus dapagliflozin reduces the percentage of apoptotic cells, as well as the silencing of HIF-1 alpha. And the findings goes in parallel with the percentage of HIF-alpha staining in these cells. That is, markedly increase following damage from contrast mediate, and is reduced after giving dapagliflozin. A second interesting mechanism that is becoming interest of intensive scientific research is ferroptosis. Ferroptosis is something relatively new in the scientific community, since it was first hypothesized and described just in 2012. It is an iron-dependent cell's death characterized by the excessive accumulation of iron and lipid peroxides inside the shell, leading to oxidative damage and to the cell membrane, and finally to the cell death. And ferroptosis is a kind of cell damage that has been linked to tissue damage in several systemic diseases that are mediated by hypoxia. This includes disease of the nervous system, such as neurodegenerative disease, the heart, that is myocardial infarction and ischemia, hepatocellular carcinoma, other type of cancer, and interesting, acute kidney injury and chronic kidney disease. Ferroptosis has a strict link with the hypoxia and hypoxia-inducible factor. Indeed, hypoxia-inducible factor 1 alpha is a negative regulator of ferroptosis. Conversely, hypoxia and HIF-2 alpha is a positive regulator of ferroptosis, and the balance between 2 factors is very, very important in maintaining a good percentage of this cell death that is making the difference between final tissue damage or tissue recovery. And there are experimental data showing that dapagliflozin treatment in experimental model can improve renal tubular ferroptosis. In these experimental studies, these mice were made diabetics following injection of streptozotocin, and were treated with nothing, or glibenclamide, or dapagliflozin. And you can show from this slide, well, you can show, you can, it's not very clear, but you can show that patients who were diabetic had a high percentage of ferroptosis in their tubular cells and marked mitochondrial and cellular damage. These signs were substantially not changed, but by treatment with glibenclamide, but were completely improved following treatment with dapagliflozin. And finally, another important mediator of the effective, positive effect of SGLT2 inhibitors in the kidney or in the cardiovascular system could be mediated by members of the Sirtuin family, in particular Sirtuin 1 and Sirtuin 3. This is very important because Sirtuin 1 and 3 can be mediator of and stimulate hypoxia-inducible factor. And they are being hypothesized as also mediator of the erythropoietic effect of SGLT2 inhibitor. In these experimental studies, dapagliflozin was able to improve the changes of cells in which were induced acute myocardial infarction, and this cardiomyocyte express when following Dabagen, this cardiomyocyte express less sirtuin, especially when exposed to hypoxia. However, when dapagliflozin was added at increased doses, sirtuin expression was increased. And last, very, very important point that I want to discuss you this afternoon is that the erythropoietic effect of SGLT2 inhibitors remind us a lot the effect of HIF-PHI inhibitors for well, two reasons. First, both of them seems to be our answer to tissue hypoxia. Second, both of them as a final step, a stimulation of the production of endogenous erythropoietin, and also that both treatment increase iron availability. Aware, and you can see from this slide that also treatment with HIF-PHI inhibitors has an effect of the quantity of oxygen in the kidney, having the capability of increased PO2 in kidney tissues. However, we have marked difference with these two treatments if we think about hard endpoint. In this meta-analysis of more than 13,000 patients, including 26 studies of patients with non-dialysis CKD, we can see that the final effect of renal disease progression is not clinically significant, and more important, even against this agent, rather possibly better in the placebo group. Notably, the patient enrolled in these trials were not probably the right model to test the possible renoprotective effect of HIF-PHI inhibitor. Indeed, many of these patients, more or less half of these patients, had already stage 5 CKD at baseline. Moreover, no information was given on baseline proteinuria, and no information is given on single nephropathies. Similar disappointing data have been obtained with these drugs on cardiovascular events. Indeed, despite great expectation of good, let's say, favorable effect on the cardiovascular system, this agent just proved to be non-inferior at best compared to ESA in this respect. And well, why there is this difference? Because we have two different agents with similar mechanisms. One class, SGLT2 inhibitor with striking effects, and on the other side, a class with similar antianemic effects, even more potent antianemic effect, but without the same good findings on cardiovascular and kidney endpoint. Well, first consideration, the patient who receive these treatments are different. As we have observed from my presentation, patients receiving SGLT2 inhibitors need or receive anemia treatment just in a minority of cases. So more likely they have a lower degree of anemia and for sure a less advanced chronic kidney disease. And this could be an important point. And another important point could be that this agent could give, let's say, different balances and different local activation of the HIF system, giving in the end different final results at a tissue level and organ level. And I'm arrived to my conclusion. SGLT2 inhibitors significantly increase hemoglobin and democratic levels, as I show you this afternoon. The effect is seen at all CKD stages, and it is independent from the anemic status. The increase in hematocrit is one of the strongest factors linked to the neuroprotective and cardiovascular protection of SGLT2 inhibitors. And finally, I'm sorry to admit, the dynamic of VTH of the HIF system and its consequence is still a matter of debate. And I thank you for the attention.
Thank you very much, Professor Vecchio, for this great intervention and this very nice presentation that led us to our panel discussion with Olga Balafa and José Manuel Valdivielso. And I really would like to start talking about these mechanisms that are not very well understood for most of the nephrologists. Sometimes we just do things like okay, they said that increased hemoglobin or hematocrit, which is like a slightly different. Maybe we should talk about this as well, because you were talking about hemoglobin and hematocrit, like mostly they talk about the same thing, but that can be a little slightly differences between both of them. And what are those differences in mechanisms of SGLT2 inhibitors in terms of cardiovascular protection and hemoglobin increasing in CKD population? So what's your impression about this?
Well, thanks. This is a very good question. First of all, I talked, let's say, of both parameters, hemoglobin or hematocrit, but I agree with you that they are not definitely the same, even if they give a similar information. And the fact that I use both, first of all, reflect the different type of specialists who made the design of studies. So as a nephrologist, we know very well that hemoglobin is a more sensitive marker of to define anemia. And for this reason, we use hemoglobin much more than hematocrit. Conversely, hematocrit is influenced more by, let's say, volume. And so other specialties use more hematocrit than hemoglobin. And this is especially true in the early study with SGLT2 inhibitors who were made by diabetologists and not by nephrologists. And I mean, interesting, it's to have a look to the analysis included both. And interesting, hematocrit is more powerful than hemoglobin. So making clear they are not the same thing. So probably we cannot completely divide the effect that we see on true erythropoiesis to, in the end, the volume. So
Yeah,
we can assume it's true that it's not hemoconcentration, but something in that respect is going on. If not, I cannot see an explanation why they behave differently.
That's a very good point, because that can be like a double explanation. The first one can be like this explanation on erythropoiesis, but there are just a little bit of hemoconcentration.
Interesting, there is one study that I didn't show you because of lack of time, that was also comparing the changes of, let's say, other hematological parameters, including mean corpuscular volume, that was exactly the same. And the only thing changing one was red distribution white. That was increasing patient receiving SGLT2 inhibitors compared to patient receiving placebo. But I think that need, let's say, more detailed and sophisticated information on these aspects, because we need probably to study this or take in consideration all the hematologic parameters, and also in the meanwhile measure more, let's say, sophisticated the volume.
So thank you very much, Professor. What are your impressions about these differences or these hemoglobin concentrations in terms of metabolic parameters, or in terms of regulating HIF? Professor Valdivielso, do you have any clue about that? No.
Well, yeah, I find this field fascinating by several reasons. So the first one is that actually these drugs were not designed for doing this. So this is really interesting. So this is a side effect, actually. So these drugs were actually built and used for reducing glycemia in diabetic patients, because the SGLT2 transporters are in the proximal tubule, and they actually reabsorb glucose and sodium at the same time through a positive gradient of sodium. So this is fascinating. So we don't really know exactly how do they work. How do they actually increase hemoglobin? As Lucia has said, there is now everything kind of points out to an increase in HIF, but it's really interesting that some cell types like cardiomyocyte that don't have SGLT receptors or transporters, they also respond in vitro to this drug. So probably we're again seeing this strange effect where a drug that is released to the market for one target has very other off-target effects that sometimes are even better than the original one. And I guess that's really interesting. And something I really is still not really I'm not still really convinced is whether this effect, this positive cardiovascular effect, is related to the increase in the market in the hemoglobin, right? Because yeah, let's see.
No, go. I didn't want to interrupt.
There is, yeah. So the point is, in these studies, that what they see is a really nice, a very strong association. That association doesn't really always mean causation, right? So association means that probably both of this of the effect on increasing hemoglobin and the effect decreasing cardiovascular event are through similar pathways, but not really the increase in hemoglobin is not in the causal pathway, right? So now there's a lot of research going through try to understand what are the effects of these drugs in something called autophagy. Autophagy is something that the cells do when they are under stress and they need to survive. So cells, when they try to survive, they are stressed out because they don't have nutrients, for instance. So they sense that this is a nutrient restriction environment because you are losing glucose everywhere. So the ketonic bodies everywhere, and you see, well, this is a state I had to survive. What they do is just do this process called autophagy, where they kind of recycle everything they don't need in the cell. So they put in lysosomes and they break it down and they obtain energy and amino acids and etc. Right. So every time that autophagy has been blocked, at least in cardiomyocytes and isolated heart, the positive effect of SGLT2 inhibitors has disappeared. So, well, and we know for other studies, of course, the HIF-PH patients were not the same, but you see there's a nice increase in hematocrit, hemoglobin, and the positive effects is gone. Remember the old ESA trials where you could increase hemoglobin, or in that case, hematocrit to normal levels, and still that was even worse, like it happened in HIF. So I'm not still really convinced that the positive effect of SGLT2 inhibitors in the cardiovascular health is mediated by the increase in hemoglobin. I don't know, Olga, what do you think?
My greetings to all of you and to our audience. Lucia, thank you for your detailed and excellent presentation. Well, I thought at the beginning that this increase of hemoglobin was hemoconcentration, but I think we all agree that it's not just this. Okay, but we don't know the mechanism. I think that cardiologists have more things to say about this increase of hemoglobin and use of SGLT2. There are studies in heart failure patients with or without CKD, with or without diabetes, with reduced or preserved ejection function. And when they use SGLT2, there is an increase of hemoglobin. There are less episodes of anemia. There is less use of iron. Cardiologists, as we nephrologists, use iron for supplementation and correction of anemia and so on. And there is a study in Natural Cardiology a year ago, and it was an elegant study using MRIs, in cardiac MRIs, in TAF2 sections, baseline and 6 months after the use of SGLT2, and they noticed that the heart failure patients taking SGLT2 and empagliflozin, there was an increase of iron inside the myocardial cells, and thus was associated with better cardiac function and with erythropoiesis, with increased erythropoiesis. So sure, we don't know a lot of things. Maybe it's a new fascinating area of mechanism to investigate, but I think that something more than just hemoconcentration, something specific happens in a cell level, and we're going to learn that later. And if I can go on, for me, that increase of hemoglobin is something fascinating for dialysis patients. Because if that is true, we can justify their use in dialysis patients. And of course, we don't have a trial yet, but there are ongoing trials in dialysis patients taking SGLT2 with cardiovascular endpoints, and maybe these trials are going to give us more answers in the future.
There are actually some of the questions here in the chat about these improvements and the ability of these improvements in dialysis population. Of course, is dialysis population that you're talking about in randomized clinical trials ongoing. They are like with residual diuresis, of course. But do you think, and there are some other questions about these anti-inflammatories or potential anti-inflammatory effects of SGLT2 inhibitors, like talking about ferroptosis and this iron-dependent cell death that goes directly with ferroptosis, and this ability of SGLT2 inhibitors of increasing this bioavailability of iron with the use of SGLT2 inhibitors. And there are just some questions about this and about the role of the possible role of JAK2 in SGLT2 inhibitors for correcting anemia. Do you know anything about JAK2 in SGLT2 inhibitors?
Well, let's start from somewhere.
Yeah. I'm
Uh,
linking some questions for
well,
anti-inflammation and inflammatory effects.
so let's start from the easiest one. So if we want to imagine to use SGLT2 inhibitors to correct anemia in our patients, and first of all, we need data, because as I show you, we don't know yet if patient with more advanced disease can have a significant increase in hemoglobin level, or at least a sufficient increase in hemoglobin level when treating with SGLT2 inhibitors. First question. Second point, we don't know if in the future we can imagine a combined treatment for our patient, that is SGLT2 inhibitors plus HIF-PHI inhibitors, if PHD inhibitors or erythropoiesis stimulating agents, in order to achieve the desired hemoglobin level we want to achieve, but possibly reducing the thrombotic cardiovascular risk. And third point, that, I mean, further speculation, we know that from our trials that we cannot increase intentionally hemoglobin level above 13 with erythropoiesis stimulating agents. So we have to accept that our patient might live with anemia. And this, we have never, let's say, demonstrated that this anemia reduce quality of life, and that improving hemoglobin improve quality of life. But if we can imagine a combined treatment that will allow us to obtain normal hemoglobin level in our patient and improve the, let's say, cardiovascular safety, which would be the, let's say, the best goal we can imagine. And well, I think that dialysis is another field of big exploration for the future, because these drugs are so surprising for the scientific point of view that we started from the effect on glucose, that it was definitely mild, and we arrived to demonstrate that these drugs are effective in patients that are not diabetics, but the effects are not are positive in both groups, but are not mediated by the same mechanism. And in this respect, we have to pay attention. For instance, if we look at the renoprotective effect of SGLT2 inhibitors on hypoxia of the kidney, we can see that SGLT2 inhibitor, let's say, improve hypoxia or change hypoxia in patients with diabetic nephropathy, but no measurable effect on hypoxia in patients without diabetes. So this makes things complicated. And the most complicated things is to divide the effect of these agents from their tubular effect, that in dialysis we should expect that is marginal, from their, let's say, systemic effect, because as José pointed out, these drugs are effective on the heart, but cardiomyocytes do not have the receptor for SGLT2. So, I mean, we have still a lot of things to understand. And if I can add to the comment of José, autophagy and also the metabolic part are also related with hypoxia, because we do know very well that the regulation of hypoxia-inducible factor is toward mitochondrial function, oxidative stress, and the metabolic response to hypoxia. And there are interesting data showing a link between ketogenic bodies and hemoglobin and positive effect. So this is another important mechanism and another, let's say, topic for further research. In just 10 days ago, unfortunately for me, I made a very, very different presentation on the role of hypoxia and HIF-PHI inhibitors on vascular calcification, complete different topic. But the final message of that presentation was that probably the true unifying factor governing the response to hypoxia is made at the mitochondrial level, at this very, very cellular level. So every single organ, and let's say vascular calcification from the bone, from the kidney, have their response to hypoxia that is mediated by so many factors, but the final actor is at a very, very small level, that is mitochondrial, and the capability of the cell to survive.
Yes, well, I totally agree with you in everything. Going back to the idea of using these compounds in dialysis, again, with the old data of the old, let's say the old use or the original use of the drug, it wouldn't make any sense. But now we know that that it can act in, as you say, in several organs. One of them is the liver. So the liver actually is the source of erythropoietin during development. And when you become an adult, you are fully developed and your body is developed, the kidney is taking over. So the liver actually maintains that capacity to produce EPO. And probably a lot of that EPO that is coming in these patients with really reduced kidney function probably comes from the liver, with a direct effect of SGLT2 inhibitors over there, probably in the receptor, right? Again, this restricts the effect or the possible effect, pleiotropic effect, is for sure related to hypoxia. Let me add not just hypoxia, but let's say caloric restriction or stress, stress related to lack of food. So for many years, we know that this idea of caloric restriction to actually make life longer and live longer and healthier is not, I mean, it's something that is true. I mean, caloric restriction is a way to make animals live longer. These small animals like worms that you restrict calories and can live almost forever, right? I don't know if that is something meaningful in our organism, but probably it is. So this effect of SGL2 inhibitors sending that stress signals into the cells, you know, you are running out of food. So you gotta kind of you know, be aware of there's no food, and you gotta do everything in your power to survive, right? That signal that is actually mediated by Sirtuin, like you say, Sirtuin 1 and 3, is touching many pathways that could explain most of those effects. Yeah.
Well, this is a very good comment. First of all, because, well, Sirtuin are called deprivation sensing molecules. So, and they are markedly inhibited in the presence of diabetes, of obesity. And in my opinion, the big difference, the only big differences that I found in to the response to HIF-PHI inhibitors compared to SGLT2 inhibitors is that SGLT2 inhibitors can restore the Sirtuin system, whereas HIF-PHI inhibitors do not seem to have an effect in that respect. So probably this is the difference, but I mean, that are definitely preliminary. And I lost track of the first part. The problem of dialysis. Well, I think the first question we have to ask ourselves is if we want to imagine SGL2 inhibitors for all dialysis patients, or we need a little bit of diuresis. This is the first First point. And there are interesting data also that are trying to use SGLT2 inhibitors for maintaining the ultrafiltration capacity of the peritoneal membrane. So another really fascinating path that
Yes, there are some data or some preliminary data about how to maintain residual renal function in hemo or PD patients, and I would like to talk about like one comment more than a question that was very interesting about the effects of hydroxybutyrate. Requiring to increase of hemoglobin are much higher than levels achieved by SGLT2 inhibitors. And Professor Casas was thinking about the role of improving iron availability and reducing inflammation. Do you have any comment on this? That was another point of metabolic effects of SGLT2 inhibitors.
Yeah, as I pointed out before, this compound have an effect on the HIF system, and so they have the capability of increase HIF activity, and for this reason there is a link with then the increase in erythropoiesis, and possibly so there is a link between let's say the good effect. And if I can go back to José's question, there was the difference between the liver production of erythropoietin and the kidney production. There is one cardiologist, Dr. Parker, that is one of the ones that work more on the mechanism explaining the increased erythropoiesis SGLT2 inhibitors. And among his hypotheses, he says that increased erythropoietin is due to liver production. Said that I didn't find any single study proving that. So at the moment, it's just speculation. And also I think there is a difference between cardiologists, diabetologists, and nephrologists from the cultural point of view on erythropoiesis and erythropoietin. So they assume that there for sure liver erythropoiesis, liver production of erythropoietin is involved, because in the presence of kidney damage, the kidney is not able anymore to produce erythropoietin. But the experience we have had with HIF-PHIs inhibitor is not that. So it's true that some HIF-PHIs inhibitors stimulate the production of erythropoietin from the liver, but not all. And I mean, we need sophisticated methods to measure where erythropoietin is coming from, but very difficult in my opinion.
Well, we need a trial in anephric patients. That will be
yeah, exactly. Good point.
I think that could be a good point, but it's still a little bit difficult to achieve. Yeah. And there are a couple of questions. There are many questions from the audience, but there are a couple of questions about the other way around, not anemia, but polyglobulia. Oh, yeah. Yes, we didn't take this point, and just a brief comment on that, on polyglobulia. What should we do in that scene? The prothrombotic effects that could be, or that we could have in the use of SGLT2 inhibitors, because we have these options as well. Well, brief comments.
First observation, as I showed at the beginning of my presentation, the effect of SGLT2 inhibitors on hemoglobin increase is present in patients who are anemic, and also in patients that are already starting with normal hemoglobin values. And as a consequence, if we give SGLT2 inhibitor with a patient with, let's say, relative high hemoglobin level on the upper part of the normal values, we can move into the definition of polyglobulia. Said that, there are, let's say, two possibilities. First, we can unmask a true polycythemia, And for this reason, in every patient that in which following treatment with SGLT2 inhibitors, we observe a marked increase in hemoglobin or hematocrit, we need to look for sign of polyglobulia, that is test for a JAK2 mutation, first of all, and look for the coexistence of increased leukocyte or platelets, and look for, it's called aquagenic pruritus or splenomegaly. And this is one point. Another interesting point is that it has been recently recognized that patients with IgA nephropathy are at increased risk of polyglobulia following SGLT2 inhibitors. And in this respect, we just collected in our department for a thesis of a fellow data from all the patients we have with IgA nephropathy. And we had at least 5 cases of polyglobulia in patients with IgA nephropathy. And it has been recently described that this patient, the immune complex with polymeric IgA can stimulate transferrin 1 receptor and secondary stimulatory superase for a very, very specific mechanism. And also patients with IgA nephropathy can be associated with true polyglobulia, polycythemia. So, and the last part of the question is to be answered is what to do with this patient, because from one side we have a very, very useful drug, and if the patient develops polycythemia, I mean, we are not very happy to stop it. And according to recent data, it looks that very, very amazing. SGLT2 inhibitors, despite increasing hemoglobin level, also in patients who are not anemic, if we look at data from meta-analysis, there are no single signalation of increased thrombotic risk with these drugs. And in my opinion, this could make us relatively comfortable in not necessarily stopping SGLT2 inhibitors in patients who developed polyglobulia who have not, of course, polycythemia. Polycythemia is a complete different setting because it's a disease with an increased thrombotic risk. So it's another story. But let's say there is a recent view that in patients who develop polyglobulia with SGLT2 inhibitors, treatment can be continued.
Thank you very much. Professor Balafa, do you have any comment on that? Just a 1 minute comment. Do you believe this is like we should do, like continue?
I think that Lucia gave a very clinical answer to the question because he's an excellent doctor, apart from an excellent presenter. No, I think I don't have to add something to this, but maybe I'm really curious about the future. What's going to bring us about these drugs? What else are we going to see about this medication?
Yeah, and I think this is what we are going to give as a last message. What is the future about SGLT2 inhibitors? Cardiovascular, renal, increase in hemoglobin, good results in terms, maybe good results in terms of an immunomodulator, or maybe good results in terms of anti-inflammation as a molecule. So still a lot to say and a lot to learn about these new molecules and the combination with other molecules that we do not have enough time to talk about today. But still another point, what will happen when we combine all the positive effects of the pillars we are treating our patients nowadays in our renal community and our cardiovascular and renal disease patients. So we just have 1 minute to say thank you very much for attending this presentation today. That was a very clear presentation, and there was a very nice discussion about mechanisms that are still known and mechanisms unknown about SGLT2 inhibitors, and we will see what the future holds. Thank you very much for being here.